I'll give you a little bit of background on myself. Maybe that'll be a helpful icebreaker. I always like when I'm in a room like this and I've got somebody speaking up front to know that they maybe put their shoes on one foot at a time and tie their laces, and yes, they wear socks, or those sorts of things are important pieces to know that there's a real human being and that the things that they're talking about has some level of relevance maybe to me. And so with that, I'll draw your attention to a couple of things. I don't have a Zeiss lapel, pin, or name tag. I'm not a Zeiss employee. I have worked with Zeiss, though, however, since about late 2007, early 2008, and have made some very strong commitments in my practice. And I'll share with you a little bit about that in the second half, what my practice looks like. But from a practice standpoint, every piece of Zeiss equipment that I have and every Zeiss product that I'm using, we have paid for in the practice. I want to be really clear on that. I think that's an important piece. We're not a center that just gets stuff gifted to us. We have to make a business case and use case for the things that we're doing. And so Zeiss has been a great partner for us, and we've made some choices in that regard. And that's part of the reason that I'm here this evening, to share what that's looked like and how that's maybe changed or progressed over time. The second piece that I'd like to share with you is, as Dane alluded to, I do have a big family. And I am not, I actually wasn't 3 weeks in Australia. That would have been great, Dane. There was 2 weeks, you were vacation on you, right? That was it. I've been in Australia for about a week, a little bit over a week, which has been great. You guys have a fabulous country, and I will tell you, there is nothing for me, at least, to have it that's more welcoming than to walk into a place that feels familiar after being abroad for quite some time. I've been abroad since October 15th. I actually left on October 15th to visit our son, our oldest son, who is 14 and studying in northeastern China, with a school that my in-laws founded about 20 years ago, roughly, an international school. So he's a freshman in high school, studying there along with his cousin. And so I got a chance to spend a little bit of time with him on way to South India, where I lead a medical mission that I've been leading for about the last 14 years. And on this trip, which was, I think, trip number 10 for the team, we saw, as Dane said, just over 5,000 patients as a clinic. We did about 3,200 evaluations on eye care patients, another 1,200 to 1,300 visits for general medical with 2 ER physicians that were alongside, and another dental team, a dental college that's local to the area. So we're in a village that's about 3 hours away from any major city. So getting into these villages can be a bit of a challenge. Getting out for care is even more of a challenge for these patients, and which is why we've also been going back to the same set or the same geography over the last 14 years to make a more deeper impact and a team alongside them in things that they want to do for their community. So we just finished that up, and I packed up a few things. I'll actually have a little video for you that's very brief, but we actually had a Cirrus 500 with us in country that was hooked up to an old generator, thanks to Joe's team helping to coordinate that and get that into these villages. But the individuals that we serve there, and it's part of the reason that we get a chance, I think, as optometrists to do the things that we do, is the giving back component. But the individual we serve there takes about 3 days for them to bus out, stay in a city, get cared for, and then bus back. So they can take up to a half week off or longer to get care. And by bringing the care into them, we actually are able to do things like we've negotiated cataract surgeries at $25 an eye. We provide glasses where we're providing the frames, and they're all brand new frames through donors and companies out there that are large manufacturers on the frame side, but we pay for the lenses to be made in country in hopes of teaming with some of the local opticians and opticals to infuse money into the local economy, rather than strictly just coming in and dropping, as a lot of American nonprofits do, and probably nonprofits around the world or NGOs around the world, tend to drop resources into places without trying to leave a lasting impact on community. And most importantly, we team with the group that's on the ground. And that group that's on the ground has been there for the last 30 years and are indigenous and have a vision for their community. So we get to work alongside them and help bring to fruition some of their visions. So got a chance to do that, popped out into Singapore and then into Perth, and I felt like I was in San Diego, which was really, really nice after, showers can be hit or miss. Internet, even though we're out in the village, can be a little shoddy, so it's hard getting in touch with the other 4 of my children and my wife, who at that point in time were now visiting my son in China and have since flown down and met me in Sydney about 3 or 4 days ago now. So There you go, full circle, and you got your orders in. So without further ado, let me dive into a few of these pieces, and we'll talk a little bit about technology tonight. Before we talk about technology tonight, I want to, just a quick show of hands, how many are you familiar? There's 2 studies that were done in Australia. So my hopes in coming here, and excuse me if I drink a bunch of wine while we go, it kind of keeps my throat going. So here, in Australia, one of the things I wanted to do as I came in was understand a little bit more about the country and about the practice of optometry and eye care and what eye care delivery looked like. The last thing I wanted to do was come in and say, well, this is how we do in the States, so guess what? This is what you should be doing and this is what it should look like. But actually to learn what are the challenges, what are the issues, and I stumbled across a few things. Obviously, my study wasn't comprehensive, but there were 2 major studies that have been performed in the last maybe now 10 years, almost 12 years, since these studies were published. And one was on oversupply. Anybody familiar with this study, the optometric supply and demand study for Australia? Some of you are, and have seen this study. And I wanted to just draw your attention to a couple of elements within this. So it's acknowledged that there's between about 4,500 and 5,000 optometrists between Australia and New Zealand, I believe. Or NZ, right? Is that, am I getting that? Somewhere in there. So about 4,500 to 5,000 optometrists with a projected oversupply of about 1,200 ODs. Now, this study, as I read it at least, looked a little small in my view. It seemed to not be very broad in what it looked at. It only looked at things from one real perspective, I felt, or maybe just cursory touched on a couple of other realms, but didn't really dive into the disease demographics. So it acknowledged that there was a growing demand of patients, or there was a growing set of patients. It set forth the demand for eye care services on your Medicare only, not a consumer-based study, which I'm sure there are companies out there that could probably do a much more effective job of taking a look at what motivates consumer demand and why they want to be there. And then tied that to a little bit of aging and disease, but didn't really significantly dive into that. Now, aside from this study, anybody familiar with the study that was published in 2005 by your Department of Health on eye care services and disease? It had a significantly different perspective, not on the supply of ODs or the eye care, how eye care would be delivered, but in particular, I think, around the market opportunity. And so I'll draw your attention to just a few statistics in this particular, with regards to the summary of this particular eye health study, and that was the changing demographic within Australia. So the changing demographic, mind you, this study started in 2002, was based on World Health Organization data, and moved with projections to 2032. And it was on assumptions at that time that were on current immigration policies and everything else. So these numbers could have changed, admittedly, but I want to just highlight a few of these pieces. And likely if they change scaling up, not scaling down, just based on population growth and cities and all sorts of other things, birth rates and such. But what you see in this study that I think is a key component is you're moving from a total population over 55 of 4.4 million to 8.9 million people in that span of time, in that 30-year span of time. So you're going from a ratio of 1 in 5 in the population to 1 in 3. And what do we know happens when we move from under 55 to over 55 with regards to ophthalmic or ocular disease? We see that piece begin to change, right? Now there's a couple of other pieces that were within this. They established their base ratios, and I put a little bit of a contrasting piece on there so you knew how those compared to the last study. But first off, just draw your attention to that little 9.7 million. That's one site problem. That's not a duplicate. That's not saying somebody had a cataract and myopia. That's not somebody saying they had glaucoma and diabetes. It's one site problem only. At that point in time was again in 2002 at 9.7 million based on those demographics. We know that number's increasing or changing over time as well. Just on current epidemiology and if you were just to kind of look at a traditional clinical medicine approach and an epidemiological approach to a study of the market. So that piece is moving forward. But the second piece here is this little ratio. So you've got 2 OMDs or ophthalmologists to 14 ODs to 100,000 people. And those ratios, when you actually look at the study that was done, the eye care supply study, the previous study that I referenced in terms of talking about oversupply, they used a slightly different ratio, so they were assuming an 18 to 100. Now, if you just take those numbers by themselves, you're talking about 5,000 patient population basis to 1 OD versus maybe closer to roughly 6,000 as a patient basis per OD. So somewhere in that 5,000 to 6,000 range, and that's general population, with an acknowledged component that 50% of the population at this point in time had one sight problem of some sort. So 2,500 patients. Let's get even more conservative than that. Let's say that number was 4,000 to 5,000, 2,000 patients per OD. Now, it doesn't take into account a dense city population versus rural. I acknowledge that. But just looking at it from a purely numbers basis, there's some opportunity that's here. And I want to take that one step further. And that step is just taking at the current number of conditions in 2002. So I'm just circling that first column. And this is in AMD, cataract, glaucoma, diabetics, diabetic ret, and then just a total number of all of those. And these are rounded. They're not exact figures. But when you look at these pieces, I put those conditions up specifically because they're conditions that, to my knowledge, Australian optometrists are able to at least participate in the management of on some level, whether it's on a co-management or detection level or the actual ongoing or starting to progress into the management of these conditions. And I think that's really, really important. And I'll draw your attention to one specific one right in the middle here, cataracts. Now, here's something to keep in mind with that growth from 1.5 to 3 million over this window of time. The supply of ophthalmologists in the same window is going unchanged. Not increasing, not decreasing. But just from a surgery standpoint alone, there is a capacity issue with regards to the management from a surgical basis of cataract care amongst your ophthalmology colleagues that are here in Australia. And this is the same demographic shift that we saw starting to occur in the US and that has driven our law changes as it pertains to therapeutics. Now, I oftentimes get the question, well, don't you guys have lasers? In California, we just got the ability to inject in October for the first time. But where you guys are at right now in terms of your law is very similar to where we were at in 2004 when I came out of the Navy in practice and was practicing in a hospital-based setting where I had everything that I could do. The other piece is that lasers in the States are in two regions that I think you would find somewhat familiar, two regions that you have in Australia. One is in Oklahoma, which would maybe be comparative to the Northern Territories, a place where not a lot of people live or maybe want to go and live. Oklahoma is that place for us in the US. It's called Tornado Alley. A lot of people do get destroyed by tornadoes there, and they're scared of Californians getting destroyed by earthquakes, which is where I'm at. And the second is that the other is in Kentucky. And Kentucky doesn't have the beauty of Tasmania, but I'm here is a little bit backwards like Tasmanians sometimes maybe are. I'm just telling you what the Australians have told me. I have no idea. So, but the scenery in Kentucky is lousy. And the scenery in Tasmania is amazing. So there the comparisons really fade. It's completely gone. But I bring those pieces up because oftentimes those are what folks will say, hey, wait a second. That really doesn't match. That's not where we're at, or that's not where we're going. Well, I will tell you, at least from when I read these stats right here, there is an opportunity that sits in front of all of us in this room as it pertains to patient care, the treatment and management of diseases and conditions. And it's not about how do I get equipment or how do I equip myself so that I can treat right now necessarily. Some of this is oriented around the detection of the condition and the building towards a clinical practice model that can effectively support what it is that you're jumping into. And some of you, as I've got a chance to meet with or be in practices here, are doing things that are on the cusp, that are driving that edge. And technology is going to be a leader for you. It's going to be a reason why you could or couldn't participate on scale. So without further ado, we'll dive into the technology. But before I do that, let me just throw that out to questions. Are there any questions in the room? Pushback, thoughts, just a different perspective on this? No?
I think there's more diabetics and glaucoma already in 2017 than what you got in 2032.
Then here.
Yeah.
Yeah. So these were just based on the study. So I agree. Right. These were projections, and admittedly, they were published in 2005 on WHO data from 2002. So these are old numbers, and they didn't go down, right? They went up in this. Yep.
Also, the numbers is a diagnosis, and then double the undiagnosed, right?
Yeah, so this number is just the diagnosed cases. This number is not the undiagnosed cases. That's a great point. Anything else? So remember, part 2, we're going to talk about notions and mechanisms around payment, reimbursement, and business models. I think a very important thing. So I don't want you to feel like we're diving past that. But let me go on in and just dive into a little bit of the technologies that are out there. And again, we'll highlight something on the Clarus a little bit tonight. We'll talk about Sita and one of the new algorithms that's with the new HFA. We'll speak a little bit on OCT angiography, which we've been working with in my clinic for a little bit over a year now, and full-blown kind of, we blasted the market with it, and then last talking about tying it up with Forum. So here's your image of a Clarus ultra-wide field, and I'll draw your attention to a few things that are on here. There's a small circle that's right in the middle here. That small circle is your direct ophthalmoscope. Now remember, none of this is to scale because magnification varies with some of these lenses, but it's just showing you the geographic area that's covered inside the retina. The second image that's right here, that rectangle, is your 90D. So not a 70, but a 90 diopter lens, just showing you what you can get if you're pretty good with it. Obviously less magnification there. The third circle going out here, that's your 20 diopter lens, using that with your binocular indirect ophthalmoscope. The next ring that we've got going out here is your 45-degree traditional fundus camera. And then the very last ring that's going around, and you'll see it in two pieces there, is the ultra-wide field image, which is taken, and I want to just get right out there. I think the steps, people start to think, well, is it one image? Is it two images? What is it? It's two images. It's got a pretty bright flash that's associated with it. But when the staff use it, and they understand how to use it well, which takes about 10 patients or 20 eyes, it's like operating a slit lamp, and they're very quick on acquisition. We've been using it in a clinical trial basis for what are called FDA validation studies in the US. We've been using it on a clinical trial basis with all of our staff. And when I had to give the first prototype back, not only my staff, but my docs were really pretty upset as we finished that study and got ready for the next. So it was really interesting to see their feedback. And we asked patients a critical question because we noticed the flash was bright right away. And the critical question that we asked our patients was, would you have the test done again? Once it was demonstrated to them what it was, and they had the imaging device, they had the image run and all of that. And every single patient that went through the study said yes. There wasn't one that said, nah, that flash was too bright, or this was uncomfortable, or that was uncomfortable. So I think that was a key part for us, and we ran it across 3 different technicians running the images, as well as our doctor review. So we had some degree of variability. Obviously, our N wasn't all that big since it was a narrowly defined study, but it was big enough for me to say, okay, there's something here for us to consider. Now, the other piece with this is those images that you see, those are auto-montaged. Those images are not taken and then hopefully you can glue them together and you grab this vessel and that vessel and yeah, boom, there it is. They're auto-montaged. The algorithm that's written actually does that. And the field that you're looking at here is a 200-degree field. You can actually take up to 6 images. So you've got a little bit better specs on that. And this was taken, these images can be taken on a 2.5 millimeter pupil or larger. Smaller than 2.5, you get too much artifact with it. So keep a couple of those things in mind as you're taking the image. We found, and we had a dedicated room that was probably about that big right here, where we have our field in one corner and we have our Clarus in the other. And we took our images in that room where we can control the lighting. We found that wasn't a critical issue. On a 2.5 millimeter pupil, we did see with these patients that it seemed to take about 3.5 plus minutes on acquisition. Whereas if we had a pupil that was at 3 millimeters, it took us 2 minutes or less in terms of total acquisition time for the staff from eye to eye to eye. And I'll show you a little bit about how that gets taken, but you can see, and just as I scroll back and forth between these two pieces, you can see this is the same image as what's right here. And you don't lose anything in resolution when it comes to the image that's on the screen here. And I could blow this up one more time, and I have a couple examples of that we'll look at next. I think that that's really a critical piece about this, is this is as good as any fundus photography. And we'll talk a little bit about the color and those comparisons, but even at that, it's a true color. So it's got a couple of benefits in terms of being able to use the Clarus. You can actually use the Clarus in a few different modes. One is in true color, which you see up at the top, and that's represented by the large image that's in front of you. The second is a FAF green, a FAF blue, an infrared. You also have filters on the true color. So you can do a blue filter, you can do a green filter, you can do a red filter, and I've got a couple of examples of those. That's important because it operates just like a traditional retinal camera. The next piece here is this infrared piece that's down below. The infrared camera is used right now to sight the retina and kind of center on the retina. But what we found that was a lot of fun, and we started toying with, because we tend to go off of on our own beaten path in the clinic, is we started playing with mybography on it. So we started flipping eyelids inside out and getting a white gland image. So you can't do it with an infrared source that's coming from underneath like you do with a LipiView or a LipiScan, but you can get a white mybography image using the infrared light source that's on there. And it would be really cool if that kind of came out in a little bit more of a module, because you can take that and plug it in with the external eye function, and that's where we combined those two together and said, let's see if we can make this footprint a little bit more useful for us. The next piece about the technology that you should understand is that the technology is a spectrum. The technology is not as that image to the far left or your right shows, where it's got a blue, a green, and a red. It's actually the spectrum that's listed down in this piece. So sorry for the busy slide, but it really shows us what the difference is in terms of the scan. And it's without this spectrum, you don't actually get the true color. That's what gives you true color, because it's taking the entire spectrum and it's combining that as the algorithm works. So this is just your OCT. This is your setup on your Clarus. That's the chin rest, single chin rest. The camera is kind of like got a little, I don't know if you call it a geolocator or what, but as it pivots around the patient, it knows where it is in respect to the midline, so it knows if it's right eye or left. Your staff don't have to label it. So you can't get a misaligned, oh, you wanted the right eye. Yes, that would have been nice. We've all had that in clinic. I'll go back in there, get me another one. I can't relabel this one. So that's useful about it. You can see the little swivel that's around it. And then I'll highlight just two things on this piece right here. And so if you look here and you look here, there are two drivers that are centered on the pupil. My staff actually found that when they started to take images on the Clarus, they never had to look right in here at the retina until the very end. The only time they looked at the retina at the very end was to get a fine focus. But what they did to draw the image in was they paid attention to what was happening in the centration on the pupil, and aligning those two pieces got it right into where they needed to take the correct image. And then when the fixation target switched, they switched that over. Now, with the Clarus, you do have some of the challenge with the eyelash on a more narrow eyelid or a more inset eye. So you just got to be cognizant of that. Again, after about 20 eyes, 10 patients for each of our staff, they got used to where that was and they saw it right away. And we're able to just tell the patient, just pull their eyelid down just a little bit. So from a comfort standpoint, now they don't have to jam their face in there, and maybe there's just a little bit of a pull down that's happening on that lower eyelid. So red channel separation, as I was sharing just a moment ago, there's red, green, and blue separation. I like devices that connect us to a next set of utilities or devices, or that seem to have overlapping functions, because they can lead me to other management conditions. So I'm going to draw a couple of correlations to what I think relates to an OCT here in just a moment. With the red, you're all familiar with red and with green. So red-free photography and what these things tell us in our differential diagnosis. No different, that's very useful. But this piece right here I wanted to highlight for you, because the blue on this, I like the blue a lot better than what I've seen on some of the traditional cameras, and just because of what you get with the RNFL. And if you don't have an OCT and you want to know what's happening with an epiretinal membrane, the blue can be a really useful channel there as well. Now, if you have something like Forum, where you can take your, in glaucoma workplace, you can take an image of your nerve, and you can take your visual field. You could actually put this blue on there and look at RNFL changes on that photo adjacent to where the visual field changes and corroborate or correlate data and information around a diagnosis of glaucoma. So this can be another useful piece in that regard. So true color, and the reason I bring this image up is, again, back to just looking at it at scale. You can see how big that one is, and I could have got much larger. But what I'll point out to you here are these fine little drusen deposits, just in a differential. So we're looking at this, well, what is it, right? You're going to throw up different filters potentially on this, but in particular, when you've got it at scale and you've got no distortion, you actually see what's happening in the anatomy in this particular set of images. In terms of true color when it comes to a nerve, this is a really important distinction. Credit to Zeiss, other ultra-wide field. That's an Optos. They don't necessarily, in certain places, have this labeled as such, but there's only one other really ultra-wide field out there. So when I'm talking about that, you should know that I'm talking about comparing this to what my experience has been with an Optos. Okay? When we look at the different images as we go across, you see a white light image, which is, there's other technologies that are out there with white light images. They're really not very much used. The ultra-wide field technologies are using a scanning laser ophthalmoscope, and so that's a little bit different in the way that you get the acquisition. And then you've got a true color image, so you've still got that pink kind of image to the retina, or to the edge of the optic nerve, and then your red or browns around the retina. And I'll show you a few a little bit later that compare like 6 different images of a disc, and you can see how that true color is maintained through the disc, so you can get a real diagnosis as you go through it. The other piece with the Clarus that I like a lot is when we're in the image here. So you've got the posterior pole, right? Which traditionally with an image, you might get this and you might get it blown up. But somebody getting an image out here on the periphery, you kind of lose some of it gets grainy, it gets out of focus. It's just not really clear all the way out to the posterior pole. There's your disc with your posterior pole complete, and there you are all the way out to the edge. And you can see in all 3 of those images, there's consistency in the clarity of the image. That's the same image that you were looking at just beneath it. So right here, just blown up into pieces. And again, I could have taken that and I could have made it even larger on the screen for you. But it just shows you the consistency of the image. And while these are slides that we've got prepared for this particular presentation, I can't show you the slides from the study patients that we had right now, but I can tell you that the slides are identical if I were to pull these up from the patients that we have experienced. And that has to do with the way the FDA does trials. So just to share with you, that's been my experience exactly. AMD patient, when you look at this particular case and you're looking there, you know something's going on, but what is it? I blew it up just a little bit. If you were up here closer, sorry for those of you in the back, you can see all the drusen that's scattered here on the macula. I should have actually blown that up to the full screen, but again, the same kind of elements that we're discussing before, and all the way out to the edge. So you're out into the periphery, you still maintain the same clarity all the way up into the edge. And then one more example, a little bit darker of a fundus that we've got here. So we've got this especially in a lot of pockets within the US. This one, you've got an AV malformation that's in it there in the center, but you can also go all the way out to the edge and still have the same sort of demonstrated clarity as we get to the edge or to the periphery. And this last one is just a hemorrhagic PED that we're looking at. Still the same size and largeness. This last one that I'll put in before I dive into a couple of the other slides around true color is I want you to note the edge of the image comes right here and comes right here, and this image is going diagonal. And what's unique about this is not the pathology, but it's the angle at which the images were taken and the fact that, again, these were auto-montaged. So instead of going sideways, we knew that the pathology was sitting, at this like 11 o'clock or 10 o'clock sort of angle, and we took those 2 images, and then it auto-montaged those for us as well. Still the same clarity there, clarity all the way out to the edge. So glaucoma. What if we were to use this in glaucoma? Now I showed you blue, and I showed you a blue filter in it, but you need to still be able to take what in glaucoma? What kind of photos of the optic disc? Stereo pairs, right? So here's your stereo pairs coming out of that. and you'll have to take my word for this because I did it on the airplane and almost made myself sick, is if you cross your eyes just a little bit and you take a look at those, you can make depth pop out of these two images in terms of the way in which they've been snapped. So there's a stereo pair function that's on here as well. True color. Remember I said there are a couple of photos of a few discs, and what I want to draw your attention to is not the color of the fundus. I want you to draw your attention to the pink, the pink, the pink, the pink. Give me a little pink on that one. And the pink that's right in here on these glaucoma. Really consistent optic nerve images all the way through, not depending on the fundus. And the other key component of that is you didn't play with the intensity of the light source. I can't stress that enough, because how many of you have had somebody sit down on a traditional camera, I don't care what it is, if it's a VisuCam, if it's a Topcon, if it's a whoever's camera, right? And they've got to be really good at taking the photos. There's less of that in this particular unit and device from a utilization standpoint. Here we are on fundus autofluorescence. Now, the difference in our FAF green and our FAF blue, or FAF green, right, is getting us out to the edge of geographic atrophy. So that's the other corollary of the draw-in. If we're thinking about how does this relate to OCT, FAF green can be really useful for that. FAF blue just is absorbed in the pigments. And so here are 3 different images, and all 3 of those images blown up into the posterior pole. And you can see the quality there, but you can see the edge of the geographic atrophy that actually shows up on FAF green, which is somewhat masked here behind the FAF blue, and is difficult to tell where the outline of it is. Now this image is so good that there are algorithms that are in process and being developed to actually measure FAF green and compare those over time. So it's a unique measurement tool, and again, a crosswalk. I'll reiterate that again with regards to OCT technology and the possibilities there. This is just a quick comparison of the Spectralis Blue Peak and the Clarus FAF Blue. What I want to highlight about this one is when we get into this image here, this was taken on a prototype of the Clarus. This is not the actual current Clarus that's in this one. And that was early stage. The clarity that comes out with this now is much more reliable than what you're even seeing with Blue Peak. But I wanted to even show you the versions or the iterations before we got out there into the general public. And then here we have our comparisons, right, to the other ultra-wide field devices that are out there, and a comparison to what we've got associated here with our regular retinal photography. So again, traditional retinal photography, we want to know, are we looking at something that's true color? We want to see, does the image quality stand up to what I'm used to having? Or am I looking at something that's going to lead me down a path that maybe isn't the right path diagnostically to be on? So your Topcon, your Clarus, and your Optos are side by side. Now if I blow those 2 up and I look at the quality of the images centrally, you can see the difference where this is really a true retinal camera that we're looking at with the level of detail versus kind of the fogginess and fuzziness around the edges, and even the distortion. This is a non-distorted image. Remember, by the way that the image is taken, nothing gets stretched and spread all over the place. So you don't have to tease out what is normal and what's abnormal within it. FAF green here on the 2 technologies. This, again, is a true size of the image. That's a distorted, slightly distorted size of that image. These are at scale in terms of measurements and pixelation, so you can see that little bit of difference in the 2 of them. And so if you're going to get an algorithm to read that stuff, you've got to have something that is consistently repeatable from a scientific or engineering perspective. I put up geographic atrophy and cataract here because I think this is another important one. If we're looking at cataracts that are moving from 1.5 million to 3 million in the population, that's the piece that we have to keep in consideration with that is that you sometimes are going to run into these patients where it doesn't matter how good your image was, you just can't get a really good light source in there to image the retina. So something like Blue Peak falls down here because Blue Peak is affected by that cataract. Whereas when you are looking at the geographic atrophy that's right here on a FAF green, you don't see any distortion. If I blew that up, that would be just as high a quality. And you can see the image in the Clarus against the VisuCam through that cataract. It's almost as if some of it's not quite as affected by the cataract with the same eye in traditional versus using the LED and the light source that's in here. little bit more on geographic atrophy, TopCon versus the Clarus. So you can get a little bit more comparison on the colors. You're getting the full field here on the Clarus. You're getting that 45-degree image right here. When we blow those two pieces up and we put them at scale against each other, you can see the level of detail that's comparative on these two. Diabetic ret, again, another example of something in terms of the quality that's there. And then we're all familiar with these eyelashes, which are really still difficult to get out of the way in current ultra-wide field technology. That's what you can do when you can just gently pull down on that eyelid or eyelash and taking these wide field images. There's the images central. And then here are the images one more time blown up. So again, looking at these at scale, looking at these at the level of detail that you want to be able to evaluate as a provider, I think much more significant. And then this last little one, and we had this happen with either our second or third patient that we had with the Clarus. You see a little retinal break up there? I think it was our second patient that we had. We actually picked up a retinal break that was out in the periphery in an asymptomatic patient while we were doing testing and going through the initial FDA clinical trial. So you're getting these wide field or ultra wide field images for that purpose, to catch, to look for disease and conditions, and to be able to have a tool that helps you monitor and manage disease over a long period of time, not just hopefully find it, but be able to look at it and gives you tools from a measurement standpoint. These are a couple of pieces. Color, clarity, I'll give them a little bit on comfort. I think the flash is a little bit bright for me, but again, not from a patient perspective and repeatability of the test. So just warning, and we found we really had to warn patients with that, but they don't have to get their face squished, which their patients liked a lot. And when we compared that for patients, they didn't like getting their face squished so much. Many of them would have chosen, other things. So quick questions before I punch on to Sita faster. Any questions I can answer about the Clarus, about our experience with it? Yes?
How far does it go up superior than inferiorly compared to the Oculus?
You'll get, so the superior, what we found when we took superior images, well, we probably got about a 200-degree field superiorly.
Do you have to readjust, take two images for that, or?
Yes. You're always getting two images that are auto-montaged in terms of the device. You can the tech spec so that you can get a little bit wider than that, but our finding was that with the consistency that we got good field about 200 degrees. Other questions? Yeah.
Dilated pupils give you a slightly larger field or much the same?
Dilated pupils don't necessarily give you a larger field because the image capture is still just as big and you've got overlap. So once you begin to spread those two fields out, even if you were to try to auto-montage them, you're going to have gaps, right, that are in the superior sections. Now, you could take them and widen them out. There is some maneuverability within the device, and then take two larger images, top and bottom, but then you're into 4 images. What we found with the dilated pupil was it just sped up testing time. You were consistently at 2 minutes or less with testing time, and I think we would have gotten faster than that. But that was our initial, workflow in having it on a limited basis to really run the trial. Other questions?
Just patient management. If the patient got history of floaters, would
Yes.
you legally can take this photo without BIO?
Could you legally take the photo without BIO if they had a history of floaters or a report of floaters? I'm not a lawyer and I don't play one on TV, but I would probably say do BIO. I'm not going to suggest that you have this and you document the fundus, and for some odd reason, right at the very edge, you missed a little something that was out there. I'd still say BIO the patient with a history of recent onset of floaters. If they're an established history of floaters, that's going to be a clinical call that you make. There's a saying in the US, they did a study, I don't know if you guys have heard of this study, but they did a study with regards to the reason that patients sue for malpractice. And the number one reason that they found that patients sued for malpractice had nothing to do with whether or not they were treated. It had everything to do with whether or not they felt the doctor cared. So there's that adage that people don't know how much, don't care how much you know unless they know how much you care. That's the piece that goes back to it. So there were doctors that were just blatantly not practicing great clinical medicine, but because they cared for the patient was forgiving towards them and allowed them to continue to practice and care for them. Interesting stat. Other questions? Mm-hmm. All right, so that's Clarus in a nutshell. let me talk to you briefly about Sita, because there's not a ton about Sita. Sita faster. Dane, did you come up with this name? So there's Sita, Sita fast, Sita faster. Sita quickest is yet to come, but it's not here yet. No, Sita faster. So Sita faster is really faster. A couple of quick stats about it, and this is really a very simple slide with a lot of information about it. You can ignore the information to the right just to say, hey, they look the same. They virtually look the same. They're equivalent. Sita fast and Sita faster were equivalent to each other in clinical evaluation. But the key piece are these two stats right here. So you've got 30% quicker, that a Sita faster is quicker than Sita fast by about 30%, and 50% quicker than it is than a traditional Sita algorithm. Now here is the really, really, really nice thing about it. Do you have to rebaseline your patients? Easy answer, no. In an HFA3, Sita fast, Sita faster, and Sita are all talking to each other. So if you've been doing Sitas for a long time, or you've been doing Sita fast, and you're worried about, I don't really want to go this route because it's going to mean that I got to rebaseline all those patients, you don't have to worry about that. Its equivalency from a testing standpoint is there, and it's comparable data over time. The other piece is that the testing has been in place since about 2011. And you should also know that with the Clarus has been out there for about 3 years in R&D and clinical development. So that's not a new device on the market either. It's just been a device that refining some of those protocols and algorithms that I was talking about has taken some time. But with Sita fast, with Sita faster, you're now looking at a quicker clinical test. With a typical patient who's ready to sit for a visual field, you're about 2 to 2.5 minutes. You're probably closer to 3 minutes on a patient who has a little bit more struggle with taking the test. And it's only available on the 24-2. If you're using a 30-2 on managing glaucoma, first question I would ask you is why? What are you going to catch with those other degrees that are on the other side of the nerve? You're not. There's been no significant clinical study that shows there's any value there. So if you're doing a 30-2, you don't need that for glaucoma detection or management. 24-2 is it. These are comparative over a period of time with your 24-2s and fit into the same algorithm as is already in your HFA3. So if you have an HFA3 now and you are saying, well, how do I get this? Do I have to go buy a whole new unit? I'm going to step out on a ledge here and say it's an upgrade in the software. And I thought I heard, does it cost anything? No. So the software upgrade on the HFA3 for Sita faster doesn't cost anything for those of you who are already using an HFA3. Okay? Not an HFA2, HFA3. So I promised you a video from India. I don't know if there's any sound on this. If there is, I'll turn it down and talk over it. There is. All right. What you're watching is a 13-year-old running a Cirrus 500 in India for a morning after 10 minutes of training and no language skills in Telugu. And if you have ever spent any time with native Indians who say yes like this, right? This was really interesting to watch as to whether this would work at first. So he's sitting there on this device. Do you see the green star? And they do this, and then they move off. Well, could you hold your head still while and then somebody would say that in Telugu, and then they do this as they walk out. Please hold your head still. And they keep doing this. And it was on and on and on. So we had to really play with the language a little bit. But that wasn't a technical issue. That was a communication issue. I put this up here because some of us are concerned about or scared in terms of using technology. He ran this for a whole morning on black cataracts, that people were effectively completely blind in the one eye and got images of the retina and the nerve that techs of mine working in my office for years had gotten. So I put this all up there to say, and the reason we use this is because the first time that we used it, we found 50 cataracts that we would have done the wrong eye on out of 400 because the macula had problems that we couldn't see with the BIO or direct. So the OCT was invaluable in getting behind there and capturing some of the information that was in the back. But I put him up here and wanted to show you this because if you're scared of OCT or even how to run an OCT, Get your local 13-year-old and have them teach you. So with that, OCTA. And I'm just going to touch on a couple of quick things here with OCTA. Now, we have been running OCTA since early October of 2016. The unique thing about OCTA and what you're looking at all in white here is anything that's in white on this particular image is the movement or the change in the erythrocyte through the vessels. And this is not depth arranged, so you can set this at different depths in the retina, and you can actually color code those depths, which I'll show you in a moment, so that you know which layer that vascularization is occurring at. Now, what's unique about this is on the other side, there's another image that's actually your structural map, which is your en face image. So you can dive into the tomogram. You can get an angiogram and a tomogram of the retina at the same time and take a look at these pieces. And I will tell you that this has grabbed patients' attention more than any other image or any other device that we've brought in, because you can take this image and you can overlay it on a black and white fundus image and pop it up on your screen, and they know what they're looking at in a heartbeat. And when I tell them that same capillary plexus is in your kidneys, they go, so would you see if something was going on in my kidneys? I said, we'd have very strong suspicion if something's there. So they immediately make the connection with regards to these devices and what we see inside. Just a little bit about the scan and its acquisition. This is a great slide, though, that shows the different areas of the different maps. So you can see on this slide, you've got this red square, the green square, and the blue square that are going around the images. You're at superficial retina, which if you saw this on a slice is through the superficial retina here in the tomogram. If you look at the second one there, it's your deep retinal map and then an avascular retinal map. I bring that up because this is what's used when we look at this color depth imaging map. So if you saw blue in here, it's a, hey, watch out for what you're seeing. It doesn't mean they have something. There can be another reason why blood vessels are in the avascular zone, and it's not anything to do with new blood vessel growth in the avascular zone. It can be due to structural changes, due to stuff happening underneath or up above, so be aware of that. And the other one I would draw your attention to is when you think of your OCT, don't diagnose red disease. Red disease is not named after Joe Redner. That was bad, sorry, Joe. There we go. All right. No, but so red disease is a condition that we refer to in the US that's based on chasing the algorithm's diagnosis. The algorithm telling you that there's a problem here in the nerve. So you look at that and you go, well, there's glaucoma. Okay? That's not an active disease. That's just meant to draw your attention that there's a differentiation from normal. And you could have other conditions which look completely normal and should be red. Realize that too. We could go into a whole course on OCT and really reading and diving into OCT at deep levels. We do a lot of posterior segment in the US, so that's why I'm going there, but just realize that. Blue disease would be the same thing here. So in blue disease, if you have pathology, there's places where the pathology is real and there's places where the pathology is not real. Now I'll tell you a clinical case that we had with regards to when we started using OCTA. And mind you, we do what's called baseline OCT on every single patient that we see that can sit. So every patient that runs through our clinic has OCT done. But in this particular case, we were about 2 weeks into using the new OCTA technology. And 2 weeks into OCTA technology, we had a 50-year-old male that came in for a visit. And when he was in for the visit, we had both of his nerves up side by side. And we were looking at the two nerves side by side and said, there just looks to be a little bit of difference in the perfusion. We weren't looking at the colorized images. This was just looking at what looked like the density of the vessels. And there are new tools that are coming out to measure the density of the vessels, which can give you comparative analysis over time. So we're looking at these two side by side. I said, that right looks weird compared to the left. So I sent him in to his cardiologist. And he had a carotid done. And he was 95 roughly percent stenosed on the one side and 70 on the other. Got under treatment with anticoagulants, had no other findings in the retina, no history of high blood pressure, nothing at all. And he stroked before they got him in for his endarterectomy, but because he was on anticoagulant therapy, he ended up surviving the stroke, and not just surviving, but thriving after the stroke. Well, that one for me was, okay, we're doing OCTA on everybody. Even if it was one life that we ended up saving as a result of it, that was enough for me to see it in 2 weeks in. So, just a little picture comparing an FA to a deep retinal angioplex map. So this is your virtual. That's with injected dye. if you want to know if you've got a case, let's say, that was a PED, and you want to know if that PED has a vascular component to it or not, how are you going to tell? OCTA is your differential capability. So last one that I'll get you to is I'll connect you with Forum here. And Forum really exists in this ball that's in the center. It doesn't look like this when it comes into your office. Who has Forum in here? 1, 2, couple, 3. So Forum, let me draw a really critical line of distinction. Forum is a data management system for diagnostics. Your EMR or your health record is a data management system for text-based information that's associated with stuff that you've said or a measurement that maybe you have taken. But it has nothing to do with this live data and information that's coming out of these files. These files, these DICOM files, when you shove them through an algorithm, can get twisted in every which way and plugged in to tell you so many different things and connected to many other devices. What Forum does is it takes the tangible potential of one of these dynamic files and it connects it with the tangible potential of another file, and now you can do something with that. So in Forum, you have these things like called glaucoma workplace or retina workplace that exist. And what those are, it's taking all that data, all that information that you grabbed, all these pieces of equipment that look very different from each other, and it's plugging them together in a usable format. And it's allowing data to drive the exam and data to drive the evaluation of the consultation that you're looking at with the patient. So it can connect different devices, and there are other devices which create impediments, and these are usually based on the way in which another product manufacturer will allow that DICOM data to be used within Forum. Forum is not a diagnostic device in and of itself. The way Forum works, or it's laid out, you've got down this side is the patient name, and these are basically sets of clinical displays that you can put up. You can put into it PDFs or images which are flat. There's nothing in these images that you can do to twist, okay? There's nothing about that that's a file. But when you take that stuff and you put it into a file that connects, now you get something like a combined report. You could have this with a disk image. I was referencing before a blue filtered disk image coming out of the Clarus that connects directly with what you have happening in your visual field. You can look at, for example, in a nerve like this, where you've got visual field loss here inferiorly, and you can look and you can go, well, superiorly, yeah, there's a drop out of the RNFL, but let's say you didn't have the OCT, but you did have that the blue photo where you're getting a really good resolution on the RNFL. This is where this is going to be very useful for you. And if we take that a step further now, Forum is allowing us to take pieces of information that are no longer in a report format, but these are connected. So here you're looking at an image in November 16, 2010. This is a year later in 2011. That's in January of 2012. And those images are linked. And if I could put this live for you, I could actually grab the cursor on this and scroll it up and down, and each of these images would move connected with each other. I can overlay or run a graphical analysis to show me the actual documented change in the tissue over time. And that's live and not on a report that I got to keep going back. Oh, don't give me that section. Oh, don't give me that section. Oh, don't give me that section. So that is your technology update. I'm going to give you guys a moment to ask any last questions, and then give you a moment to refresh your glasses or use the restroom before we get into part 2. Any other questions? Forum or Sita Faster or any of the things we just talked about?
With the HFA3,
Yes.
you saying we could say start a patient on doing like Sita Fast 24-2 and then eventually move them up to a Sita Standard, and it would take the original Sita Fast as the baseline?
Sita Fast and the Sita Faster and Sita all can be used as a combined for your baseline. So let's say that you started with the Sita Standard, okay? And then the next field that you got on the patient was a Sita Faster. Those two can be combined for a baseline. That's what I'm saying. And if you wanted to work in reverse, yes, you wanted to go faster, but I don't know why you'd go that direction if they're equivalent, if that makes sense. Yeah.
Firstly, do you
Yeah.
have a copy of that video on the Zeiss website? Because we'd like to show our students that it might take some 3 days to learn.
I'm happy to provide it to somebody here. I don't have any problems with it. I have it free of use, so We've used it. I've used it in a lot of different circumstances and situations. Let me just share with you too. Well, yeah. So did I answer that question? Obviously, but any other questions?
Yeah, a couple of questions
Yep.
on Sita faster.
Yep.
So with Sita fast and Sita standard, it's using an adaptive Bayesian algorithm
Yep.
with a certain error tolerance to get an estimate of the sensitivity. How does that error compare in Sita faster? Because if we're using numerous different thresholding algorithms to track GPA over time, how does it account for greater error tolerance? And in that vein, does it take Sita faster longer to detect change in GPA compared to Sita fast and Sita standard, which is, I guess, the current clinical standard for this project?
So since 11, I'll answer the second question first. Since 2011, it showed that the test is equivalent in its detection capabilities and management over time. To answer your first question, I'm not a scientist and I apologize. I don't have a good answer to that one, but Mike Patella, who is in Zeiss, and that's probably who I'd point him in the direction of, would likely be able to give you a very clear answer on that would run circles around anything I could tell you.
And just last question,
Yep.
is it available in 10-2?
No, only 24-2. Yeah, and we use, like for our end-stage glaucoma cases, we're using a lot of 10-2 at this point. We're using it for other things. We're playing with some different nutritional components that we're seeing what kind of macular preservation we can get, and if we can claw back spots on a 10-2. So that would be really useful, because those patients they're long in a 10-2 even at that, and to have a faster algorithm would be useful. But to my knowledge, it hasn't been tested there yet. Maybe it is. But anybody else? All right. I'll give you guys a moment to top off and take a little bit of break. I'll bring us back together in about 5 minutes or so, okay? So I have to tell you that when I was told the kids, so it's our first time in Australia and New Zealand. When I told my kids that we were first coming here, my 7-year-old asked me, since we were going south of the equator, if everybody walked on their hands. And he was surprised when we got here that everybody was still on their feet. So I don't know where I go with that, but it was my 7-year-old. And he has amazing views of the world that teach me new perspectives all the time. My 2-year-old's just 2. Those were our last 2 surprises. Busy. My wife is busier than I am. Yeah. She does the bulk of the heavy lifting for sure. So I'm not on the road all the time, and I hate the podium, as a matter of fact, which is why I'm not really behind the podium. What I really enjoy is I enjoy the discussions. I enjoy getting in a room and hearing questions and throwing out ideas and having new ideas come. And one of the outcomes of those new ideas is the second part that we're going to discuss a little bit. Now, usually this second part is over a round table of maybe 10 or 15 of us in a boardroom style, and we kind of let the gloves off and I facilitate a really healthy discussion that can get fun at times. They're great to record on video. We also, though, decided that a little while back it would be wise to encapsulate some of the pearls that come out of this, because the pearls that I'm going to share with you here are not my own. They're learned from colleagues like ours that are around this room and around the US, and now Australia, I'm sure, will incorporate some of those things. And so there are 2 leave behinds that I will draw your attention to, and we'll get these guys to you at the very, very end. One of them has a little Zeiss logo on it here, and the second one has a Clearview, which is my practice back home, logo on it. The one that's with the Zeiss logo on it is a formalized sort of version of our FAQs, our frequently asked questions, that came out of discussions like this second part. And the document that's on my left hand, your right, is a document that we use for giving patients information from a disclaimer standpoint so they understand, and the numbers that are on here are played up, but you'll get the general idea around fees and what their responsibility is. And on the US side, we're required with some of these things to have patients acknowledge some of this stuff ahead of time. The piece that's here is a summary document of the way in which we present something that we call baseline exam. And baseline exam is not the only point of discussion. I want you to understand that what I'm going to talk about next with baseline exam is something that we stumbled on through a series of adventures. And I'll share with you a little bit about that adventure and what that looked like for us as a practice. But those are leave behinds. We'll make sure you want to make sure you get a copy of those. Secondly, we did a set of videos that I was talking about. And those videos were they're in about 3 to 3.5 minute or so snippets. Zeiss has a practice support program that they developed. And what they do on the back side of that is these videos are snippets on the topics we're covering now, tonight, in this particular part of the discussion. And they're meant to be very useful for you, either from a provider end or from a staffing end, so that you can implement some of the things that we're discussing tonight. So those are your leave behinds. The videos, I don't have access to those, but your local Zeiss reps here can help you with that and get you connected to those things. So make sure, if you haven't met them yet, because I understand that for some of you they're new faces, make sure you meet them, if for nothing else, to get access to those videos, because those videos I think are really useful. And you can actually download a copy of the document that's here in paper as well, so that you've got that. The other last thing I'll leave you with on those documents is those documents are for you to use however you wish and want. Realize that they are living, they're changing over time in terms of what we do in my practice and what other practices are doing. And they are the input of many different docs and many different practices and styles over time that have shaped what that document looks like now. So I want to put back up here, and this will be the backdrop. Dane, my last slide. This will be the backdrop for the rest of the discussion. And I used an analysis of something like this in the US to start to look at things on my practice side. So I shared with you before, it's good to know that somebody sees patients on a regular basis. They're doing this stuff. First, I don't have a silver spoon. I don't have a family inheritance that gave me my practice. I actually bought a practice that was a piece of cash flow in the US. It was about 1,000 square feet and had carpeting up the walls, posters on the walls as well, jewelry cases that were kind of crammed together to house the glasses that nobody could get at, or frames that nobody could get at. And when we went to remove the posters from the walls to repair and do some building, we found holes. So it was really interesting to have this practice and to start out with this thing. When I started into practice, my practice was kind of moving along a little bit, and I had decided some things I wanted to do. So I've been in clinical practice for about 17 years, 16 years, something like that. I was in the Navy for 3 years first, had every toy that I wanted, had every privilege that I wanted to treat every condition and not just manage them that I wanted. And I walked out into California, where in California law at that point, we didn't even have glaucoma. We got it when I got out. And when we got glaucoma, they stuck a little set of handcuffs on you and said, if you want to treat those glaucoma patients, you have to co-manage 50 of them, with them seeing the ophthalmologist and you for a period of 2 years. Even worse than saying, here's a glaucoma patient, would you please approve a drug? And then I'll write that prescription, and then I'm going to see them back if you're busy enough as a practice, right? But you guys had it yanked and given and yanked, and I understand that there's some challenges that are there with that around your glaucoma privileges. But that was our glaucoma privilege. And we have really nothing else in terms of therapeutics at that point. So we were challenged to treat or be ready for this set of conditions. Yet I knew that's where we wanted to go because that's what I had done. So in about 2007, so about 3 years into my single location, where I took a 35-year-old chair and had it refurbished, and I had a 40-year-old slit lamp, I think, and what looked like an old B&L Greens Phoropter that was sitting in there, and stuff to just try and get the practice going. I lost about 30% of my patients in the first 6 months because I was making this commitment to medical, and those patients were used to a quick refraction check and a pair of glasses. And what we have in the US is we have 2 tiers on the government side that cover our medical cover our medical care. We have Medicare for 65 and up. We have Medicaid for under 18 and under, basically under 18. And those two pieces don't play real well together. And what's also unique about those two pieces is that where they're spread out, they're increasingly becoming what's called managed care. So that managed care component limits the network size, so you can't get access to those patients. In what I might liken that to is you're really like maybe an orthoptist practices here, where they can't get access to certain patients unless they have a referral from one of you or from the primary care for somebody else. But it's even worse than that, because even if I had a referral and I wasn't in network, I still can't get paid and I'm trying to treat this patient. Everybody on the in-between in the US has what's called a commercial, or somebody, not everybody, but most people have what's called a commercial carrier that covers the middle of that road. And the commercial insurance for years was fee for service, which was great because you'd come into my practice, or you'd come into my practice, and I would say, yeah, you've got this condition, here's what's going on. And you would say, great, I've got a $10 copay, perfect. And then I bill the insurance, and the insurance would pay me the rest. That's gone. Poof. It's really gone. And it really went away when healthcare reform happened in the US. And the reason it went away when healthcare reform happened in the US is the same reason that pensions in our country transferred to 401ks. There was a shift in the financial responsibility from the payer, from the third party, to the patient. And so now, when a patient carries a $5,000 to $8,000 deductible, which most of our patients do, guess who bears the brunt of the cost? So guess who has to make a case to the patient about the care and the quality that we're going to provide. And so regardless of what you might have heard about the US, unless you live in one of those panaceas like Kentucky or Oklahoma, you have a very competitive marketplace with a very competitive payer mix. And when you sit in the middle of Roseville, where 3 miles around me, I have 11 or 12 independent practicing ODs. I have 2 large ophthalmology practices that are 2 to 3 ophthalmologists plus their optometrists that are a half mile down the road on either side. I've got a Kaiser, which controls about 25 million lives in the state of California on one side with their eye care facility, and a UC Davis Medical Center behind me on the other side, not including Sight for Shore Eyes and JCPenney Optical and Sears Optical and Stanton Optical, and I'll go down the list. That's the competitive environment that I had the stupidity to plant my practice in. I've found that some of those decisions have been the best at challenging my notions of how to compete and how to be an effective communicator with my patients, how to be an effective communicator and manager of my staff. And I've made 3 what I consider really good decisions as I went through that. One, I moved to Roseville, California because it was close to my father, who was in business and not in eye care. 25 years in executive management, I learned business from him. And I wanted that tutelage alongside, and he connected me with a series of other mentors, and that made me think about eye care very differently. Second was that as I went along, I wrote into my business plan that trip to India that I talked about, to always make sure I had something that was a guidepost that pushed me to make sure I made decisions that were going to support those notions of service. And the third piece was I hired about 6.5 years ago a manager, and I would take it beyond a manager. This is the COO, Chief Operating Officer of my practice, who is a 6-figure salary in the US, to come in and help me take the business from what it was to where it needed to be. So I surrounded myself with some of these people that did all those things. And those were really critical pieces. But along the way, I made a couple of steps or missteps that created opportunities for me. And one of those was in 2007, I bought a Cirrus 4000 at the height of the market for the bleeding edge price of $79,000 US, because I loved technology and I wanted to get into the technology. And it wasn't the Zeiss rep. He's still a great friend of mine. I really love him to death. And he's still with Zeiss. It was that I really wanted to do this stuff, and I saw the opportunity. And at that point in time, we had a reimbursement of about $120 a scan, on $110 a scan on OCT. So it made complete business sense to go and do that purchase. 10 months later, it got cut to 40, and just chopped the knees out from under me. Not only did it get cut to 40, it got cut to 40 and you couldn't do it on a macula and a nerve on the same day, which really screwed you up when you had built a business model around some of that stuff. So the first thing that I went to, because I was hungry at this point, and I think we already had 2 kids. Maybe the third was on the way. I don't remember in 2007. I forget all those things. So I get there. I get this. I'm sitting there going, what am I going to do with this? How am I going to go about making this work? So we employed what we call in the United States the Optos model. So, well, yeah, I mean, if we get a really good person at the front of house that can sell the heck out of this thing, you know what? I'll get them to convert, and I'll have them pay for this stuff in advance. And then I'll see them on the back side of it because I know that it's really clinically relevant. And if they're really good, we saw 70% conversion. If they were modestly good, we saw 50% conversion. If they were mediocre or worse, it was 20%. But one thing that we noticed consistently, and I had one other doc at this point that had started to fold in to the practice, we noticed that when they sent a patient in the exam room, and the patient said to us, Dr. So-and-so, if you tell me I should have this done, I'm going to go have it done. They did it every single time, no exceptions. And we thought, wow, that's kind of unique. Why is that? What's happening with that? And I think, and the way I characterize it is this, we operate as clinicians in one currency and one currency only. And that currency is the currency of trust. Now, trust is expressed in many different ways for us. Trust can be expressed in how they spend their money. Trust can be expressed in how they spend their time. Trust can be expressed emotionally in a smile. There's lots of ways in which it gets expressed. But the most common ways in our practices is their time and their money, right? And so recognizing that, we said, if somebody's going to trust us, we have to give them a reason to make a decision. What's that decision going to be about whether they trust us and whether they move forward with any other of our care, either recommendations or prescriptions, regardless of whether that's imaging or otherwise. And that was what we stumbled on. So we started to employ a model called baseline exam. And we said, you know what? If we're going to get to any of these and we're going to build a base of patients that we care for with any of these, we want to make sure that we go ahead and we establish that. So we said, you know, we're going to make this across the board. Every single person who walks in will not see a doctor until they acknowledge that they're having a baseline exam. And this was we ran a baseline exam, an OCT, 512, 128, and a 200 by 200 nerve scan. And if they had any questions about it, they could ask the doc in the exam room, but they had to have it done before they walked back. They didn't have to pay for anything, but they had to have it done before they walked back and have that discussion with the docs. The staff were scared. The staff thought, no way, we're going to have them walk out in droves. So the first month, we had 6 patients leave us. They were all 50-plus-year-old white males, and our staff were 25 to 30-year-old females. And 50% of those guys got the kick in the pants from their wives and were back to see us and came back and said, I am here to see you because my wife said to come back in. You have my best interest at heart, right? That, though, was a notion. We had to figure out about, you know, what does that mean around communication? But we also had another thing that we noticed once. We had a kid who came in for an evaluation. We did the whole family. We had 5 people in the family, and we charged them all appropriately as we had set forth. And this little kid was a +5 or a +6 hyperope at the end of the day. Asked about him about 2 weeks later, how'd he do with his glasses? I want to know, first exam, all that sort of stuff. And the staff in optical said didn't get his glasses. We haven't seen him yet. I said, what do you mean he didn't get his glasses? He's a +5, +6. He needs these. These are absolutely critical. And that's the quality of care we've committed to. They said, well, they couldn't get the glasses because they didn't budget for that. But they had budgeted a certain amount, and they spent that on our baseline exam. And so we made an adjustment right there and then. We actually said on families that were booking as a collective together, we did a 50% discount on our fees across every single patient that was part of that family at that point in time. And that's morphed a bit over time. We now charge for those in advance, so that if we've got a family member who wants that discount on services at the beginning of the year, if they want the discount, they have to pay for the full family for the year. So we're collecting those fees up front. It's a very good recall mechanism. We didn't realize that at the beginning, but it's a great recall mechanism. It's a compelling reason. They've already given you the money. They're showing up for that second part of the evaluation. But those are the changes that we made. And we saw tons of things. We'll see 2 to 3 cases of juvenile glaucoma a year. We'll see central serous in a 14-year-old. Because we have a macular image, and we'll turn around and talk to the patient and to the parent. We'll say, what are you doing? Dane, why are you so rough on your kid? What are they experiencing at school that your 7-month-old has central? No, we don't scan 7-month-olds. But what are we doing where we scan these patients and this is going on, and you'll see them a month back, and the kid's in great shape. So there's compelling pieces that we found in our vernacular and the way in which we started this conversation. But here's a side piece that we never expected. We looked at numbers about 18 months after we had instituted this. And 18 months after, we looked back over a 12-month window from the start to the end of it. And we said, what else might have changed in the practice? Is there anything else about us that's been adjusted? We saw an increase in our optical spend of $50 per job. $50 per every transaction that people were purchasing, it went up by $50 on average during that same window. And 4 years after we had implemented it, we saw that number top off at about $100. We had made no other changes in optical in that same window. But what we believe was happening was we put together a very narrow front door. We let patients know what it was that we were about, what it was that we stood for. We left the back door as big and wide open as possible. We didn't care about the back door because if we didn't do our job, they should be free to leave us. But if we did our job, they're not going to want to leave us and they're going to tell more people about us. And why we think that optical spend went up is because we had patients leave us. And we had one stick with us and they started referring other patients into us. For those reasons of our care was paramount and our optical was an extension of our care. And I can share with you a little bit about what we do in optical and why I think that is. But that became a really big catch for us as we looked at the ripple effects through the clinic. And our clinic now is 4 doctors. We see patients on, we have 4 exam lanes. We have about 4,000 square feet. We also have an IOL master. We do all of our own cataract pre-ops in the clinic. Our surgeons visit us and do the cataract pre-ops in the clinics. We have a conversion rate on our premium IOLs and procedures of 133%. So if each person that got a cataract and had surgery done had a multifocal and a femto, that's 200%. And so we just do that across 200, and we're at 133%. So every one of our patients gets something premium, and then 1 in 3 gets an additional premium treatment from a surgery standpoint. That's what that 133 means. That we came upon through relationship building, and because we have the technology on the back end to build it. Patients were seeking us out for the care and the quality of the care that came along with it. We've seen growth across our behavioral optometry side. So we have one provider that spends time in the behavioral clinic, generating well over what the average optometrist does to justify a salary in a week. She generates in a day and a half. Takes care of her twin girls, loves the balance that's there in life. Got another provider who's in his mid-60s, loves seeing patients, has the latest technologies, it's always at his fingertips. All of these pieces kind of came out of that vision around baseline exam. And so Clarus is going to work into that for us as it rolls out live in the US. But right now, where we're using it is in OCTA. And I shared with you one of those stories, and I could share with you countless other stories in OCTA on how we made those connections. So that's a little bit about the story in my practice. And when you talk about these slides that are in front here, and we talk about the data that's in this, if all you're thinking about is I want a piece for this, and you have no defined way at which you want to get from here to here, which I believe it's fundamental to invest in technology to get there, then you're not going to really get there. They're not just going to walk in, or when they do walk in, you're not going to be prepared to serve them in the way that they need to be served. And I would share one more thing with you that I think is the most exciting thing about this set of slides. When I look at this slide and I think back to where I was when I came out of the Navy hospital and into California and the way our laws were set up at that point in time, you guys are at the exact same point that we were. And my practice now is 65% medical. And I shared with you all the demographics around what we're doing in the clinic. And I shared with you our competitive marketplace that we exist in. And the ages that span, we've got from a 66-year-old practitioner now down to I'm 42. That's our range that's throughout it. And there's lifestyle pieces for everybody that's spread within there. But that's a little bit about us, and that's a little bit about baseline exam and why it's been so effective in our commitment to technology. Patients have to know that you're committed to their best. And what we oftentimes will tell patients at the front desk when they give us a hard time about, no, I don't want to pay that, I just want to see them, I just want to have a refraction, or I just want to have a vision check. The staff say that, there's a lot of places in town where you can have that. What we believe is that you're seeking us out because you want our best, and this is our clinical best. But if that doesn't work for you or where you're at, we'll provide you with an electronic copy of your digital copy of your records, and here are a list of 5 practices in the area that I'm sure would be happy to see you and take your plan. How many of those patients do you think walk? Very few. There are some, but they don't usually walk, because once they know the choice that they're making and the distinction in the choice that they're making, they can actually make a choice. When we're soft on the edges is where it's harder for them to make a choice. If we're humble in our presentation, but they know that they've got a distinct choice, we've got patients now who link into this stuff, and each year they're looking at a glaucoma scan and they're saying, what's my number? How does that compare to last year? They're engaged in their care. And if they leave our clinic, we take them and we say, here's a thumb drive of your DICOM data, and here are a list of 3 other practices in the city that you're moving towards. And they all have this technology, and they'll plug it into the device, and it'll pick up where it left off. It's data-driven. It's not simply just an image or an image without any measurements in it. And that's, I think, a really important factor for us. And we've got folks in the area who don't want to have it done because they get a free OCT somewhere else. What do you think we tell them? We don't tell them no. You have to have an OCT with us. We ask for a copy of their digital information. And when they go back and they ask for a copy of it on a thumb drive, nobody gives it to them. Nobody. And not only does nobody give it to them, they don't even know what to download. They download, when we do get something, it's a PDF on that thumb drive. It's not the data file. So that's a sticking piece for us. Those patients get it, that this is data-driven. This is not just a piece of paper. All that PDF is just a digital photocopy, right, of what you're looking at. We want the data. We want that tangible piece of information that's malleable and that's digestible and can be related to other things. That becomes a really, really critical piece for us. So we are, as a practice then, students of what I call behavioral economics in practice, in eye care practice. Many of you may have read behavioral economics books, or you may be a fan of economics. And I'll share kind of one last parting story and then open it up to some questions. Have you ever read the book, The Innovator's Dilemma? So there's an outline in The Innovator's Dilemma around industry, and particularly products, not necessarily service. And that outline goes like this. First, you start with features in a product set. Then you go from features to reliability, then reliability to convenience. Convenience as the market matures to what's the last one? Any guess? What drives consumer behavior? They first chose you because of features. They second chose you because of reliability. They third chose you because of your convenience. Price. Where are you at in this market? Anybody got price issues that seem to be competing against them? That is the sign of a commodity, that the market has become completely commoditized. And you know how you target those, or at least how we found in eye care and a service industry that we target those, is we create something that has features that relate to the patient and that's reliable or consistent in their estimation, but can't be quantified in the way those other pieces can. And that's the connection piece that we've had. In addition to that, in our optical, one of the things that we've done is we've limited our offering to 3. We call them a precision, a vibrance, and a performance lens. And they qualify for our progressives and our single vision. It doesn't matter what the utility is behind it, but our precision are the 167 and 170 lens with scratch-resistant UV and a high-end decode AR. We've got a vibrance lens that's the same. These are all digital lenses, by the way. That is, though, a Trivex. And then we have a Trivex with no AR. And that's it. We don't do poly. We don't do CR39. We don't walk backwards. Why would a patient want 25 or 30-year-old technology in their glasses if I'm giving them a scan on a $70,000 piece of equipment? And we think that those two pieces for us really have to align. And we don't fill every set of glasses. But we don't have to fill every set of glasses. Our glasses for us end up being an extension of our medical care. And we find that that consistently puts referrals into the practice. And that is a change that we made after that $100 increment. So you can only imagine what that was after we made those changes. So, questions, pushback, different thoughts.
Can you explain
Yeah.
how you have the ODMD integration, vertical integration setting up?
Sure, what our ODMD relationship looks like.
Integration in the practice where
So a couple of things, first off, that I think is really important to understand about the US market. The US market is significantly more subspecialized than the Australian market right now in ophthalmology. And ophthalmology is moving that way for sure from what I can see in Australia, but it's very significant in the US. There are almost no general ophthalmologists anymore. There are very, very few of them. And so what it does is it creates a relationship where when we're sending to retina because we have OCTA, we're sending to retina only when they need intervention. We're not even sending to them for checks or monitoring anymore at this point. So we're keeping all those in-house until we see them again. That's a critical piece in the investment. When it comes to cataract surgeries, that was about a 3.5-year process. And in that 3.5-year process, the first thing that we did was we said, we know that we've got these cataract cases, and really, frankly, we're tired of sending them to your office. And here's why we're tired of sending them to your office. Because we don't know what the heck we're going to get back. Sometimes we get great surgical results, and the patients are singing your praises. Sometimes we get them saying, your staff were horrible, and we don't know why you ever sent us there, and it reflects badly on us, right? It was all over the map. So we said, we really want to take this particular group of patients. We want to try and control this experience for our patients end to end. And we said, let's start with this. Why don't you do some pre-work in the office once every quarter? Let's just see if it works out. And this was a surgeon who we had a good relationship with. They said, you know what, that sounds great. He said, what I'll do is I'll bring a portable A scan in, which just looks like a tonopen. You come in and you do the portable A's. We do A's and K's. We do all the education before the patient got there. And we started to see these conversion rates. And they were 20%. They were like 40 or 50%. We said, we think we can do that better if we can get their minds and let patients really know what their choice is. So as we took over some of the education pieces and we went to every other month that he was in the clinic doing these pre-ops, which are a morning for 3 hours once a month. Now, that particular set of cases, we said, you know, we're going to invest in an IOL master. So we went out, we bought an IOL master, we put his protocols in place. We put the surgeon's protocols in place on IOL master and topography. We knew what each patient channel looked like, and then we had a clinical education specialist walk through that with them, and then I review those, or the other doctors review those, and they said, here's what we're going to do. This is what our treatment's going to look like. Well, as that started going and going and going, we saw these conversion rates rise. And so now our conversion rate of 133% on between 12 and 15 cataracts is $8,000 to $10,000 that goes in the surgeon's pocket, where in the US, they were getting, if they just did them at Medicare rates, were low and they can't bill on top of any of that. But because the patient had the selection, the patient was driving the selection. It wasn't the surgeon. The surgeon just had to come in and say, I'm going to tie that up in a neat little bow, and I agree. And it was based on their protocols anyways. That was the relationship that we ended up developing. Now we have that with a couple of surgeons, but that's kind of the key to that process for us. And it took time. It built over about three and a half years. Answer your question?
I mean, would the surgeon worry about, because you have a close relationship with your practice, and other doctors will be less likely to refer to that particular MD?
So the question is, would the surgeon be concerned because they've got co-management relationships with other offices? Would they come into my office if they have these other relationship offices that they have relationships with in getting referrals? The answer is no, because he doesn't see any patients from their practices in our practice. He only sees our practice patients. He doesn't refer any patients from his practice to our practice. He's only seeing our patients in that practice. And I think that's an important distinction, but a great question and a reason why. And we see all through pre-op in the 1 days. So the only time they're in the surgery center, the only time they see any other staff is on the day of surgery, and that's still an issue for us. We would love to control that better because they still don't have the greatest experience. But at least we got both bookends and we can control that experience as much as possible. Other questions? Yes?
Can I ask how long your baseline consultation patient is with you for that?
So the baseline consultation for just reviewing the data and the scans, or the entire consultation?
How long is a patient with you for that first visit?
So for me on a first visit, it's usually about 15 to 20 minutes tops with me. In the practice as a whole, we try to keep it to an hour. There's some great studies in the US around spends in practice and that convenience factor, that time factor. And when patients are under an hour, it drops over an hour, it drops off precipitously in terms of the spend in the practice. So we try to keep it at an hour. We're heavily delegated, so our throughput from an exam standpoint is we run a tech on the front end. So once they've checked in, then they're brought into the diagnostics room. And they're run through their diagnostic scans. If they're a contact lens patient, they've got topos that are run. We'll use on our younger non-glaucoma or non-disease patients an eye care tonometer. And so we're using that. We don't use any puff. And then we have Goldman in all of our exam rooms. When they come into the exam room and they put up the letter for just getting visual acuities, after they've gotten visual acuities and they're comfortable with what the patient said, and they've looked at pupils and they've looked at any redness in the eyes, in those cases they will actually go ahead and drop with 2 drops of 2.5% phenylephrine. So the patient's in a mid-dilated state before they see us without cycloplegia, so it doesn't affect them in the optical. If I need to get them dilated further, a 0.5% tropicamide in 3 minutes blows their pupil wide. So I don't have to spend much more time with them, but I haven't got this really long, drawn-out situation, and by the time I'm entering stuff in their chart, they're ready to go for dilation. That's an important piece. So they'll run confrontation fields, they'll run EOMs, and if they're concerned about anything at all, they flag us right away. And remember, we manage quite a bit, so we've got techs that are really used to running through that, and we had to hand those pieces off. I don't want you to think by what I just described that it was like day one, here you go, here's all of this. We had to do some testing with that. So there's one provider in the clinic who he's booked on 30-minute slots. I'm actually booked on 15-minute slots just because my variety, and we try not to template. Again, the convenience factor, because if I template too much, then I have these whole swaths that were just a bunch of glaucoma, and somebody else might want to get in there, and it becomes a little challenging. So, other questions?
Aaron, a big part of your success is that your staff really bought in. Would you agree? So for someone who's thinking about going down this path in an enhanced way, who perhaps is concerned how to engage the staff, what would you advise?
Yeah, so staff engagement, I highlighted 3 decisions I felt were really critical. My third decision was my best staff decision ever. And I had somebody ask me in, I think it was Melbourne, said, could you tell us how you go about hiring great staff? And I said, I hired one really good staff, and they take care of that stuff in terms of, we work as a team, but it's really on them to go down that road and do that well. And I contribute, but I can't take ownership of that in my business. That being said, communicating vision and the why to my staff has been critically important to their buy-in or not buying into what we're doing. And I had one staff, so from a training perspective, this was really interesting when we were first doing baseline. We're walking down the hall together, and she came up, or I was walking down the hall, finished up with a patient. She was walking towards me. She came up and she said, hey doc, so-and-so is not coming in. They decided they just didn't want the baseline, and because you required that was done ahead of time, this is gonna be that they just were leaving. And I said, okay, who's next? Those types of consistent interactions with the staff, I cannot tell you how fundamental those are to them understanding that you're bought in. They were in. At that point, they didn't need me to tell them anything else. I didn't get upset with them. I didn't say, oh my gosh, how could you let them leave? I didn't run out the door and reverse. I stood behind the decision that my staff had made, and they were able to say, yeah, this is the decision that the doc would make. So that was really important in terms of the engagement. Otherwise, it's making sure they understand why as best as I possibly can. And they do that when they see their family members and individuals who they come in and go, wow, we picked this up. So they tell these stories, and we encourage them to get these stories and own those stories themselves.
Aaron, it sounds like your patient clinical care model works on them actually referring friends, etc. But do you do much work with people with your referral base in promoting the practice, and how do you do that?
Yeah, so from a basis in promoting the practice, we're really not heavily on social media. I mean, I couldn't be a guru for people and tell them this is how you go about that stuff. We employ a couple of tools. There's a tool in the US called 4Patient Care. And the way 4Patient Care works is it helps you to assess net promoter scores. So if you haven't, or you do use net promoter scores, I think those are important pieces to understand about why a patient would refer, when a patient would refer to you. And what a net promoter score is, it evaluates that, whether a patient would refer somebody else to you based on what their experience just was. Well, what 4Patient Care does is if the net promoter score is an 8 or higher, which is a promoter, considered a promoter net promoter score, is it actually then sends them an opportunity to do a Google review. And so we've got lots of 5-star Google reviews, but not because we requested anybody to do a Google review, just because that's how it connects in. Conversely, what it also does that I think is equally important is if anybody is below that 8, it asks them to tell us why. And we go and we address that issue. And I think that's more important than going out there and getting all these other stars to happen. I think it's understanding who we didn't serve well, what we didn't do when we were trying to serve them, and correcting or remediating those pieces. And some of them you can't. Some of them was price. There's, in my case, 11 other practices around me, so that's not us. Sorry. Any other questions? I want to be respectful of your time. My pocket buzzed a little while ago, so and I'll be around. Dane, I'll get you to pass some of these guys around, and I'll go this side, and I'll answer questions as we go if you want. You got it. There you go. Joe, you want one? Just toss a couple on there. I think there's enough there for everybody. Thank you. You got it. So just in closing here then, before we take off, and do you want to ask that out loud or do you? Okay. So just in closing, before we take off, I want to hand the floor back over to Dane and let him wrap up. I got to thank you guys all just for your hospitality as a country. It's been really, really special being here. And I can't tell you, I really emphasize my experience from Perth on east, that coming to a place that feels really familiar is special, especially after being on the road as long as I've been on the road. You guys are extremely welcoming, and as a culture, I will definitely be back. So thank you very much.